before. In some patients, if we think you're at a risk, we might opt to operate on one side, see how you do, let you recover, and then do the other side, rather than doing both sides at once. There's always a risk of infection. Similar if you had a cardiac pacemaker. Similarly, if you had a hip or a knee replacement. There's a risk of infection when we put anything inside the body. Usually when that occurs, it occurs in the chest, and it means we have to remove the battery, and sometimes we have to remove the entire system. This is on the order of a couple % as well. There's also risks and side effects from stimulation. In other words, when we put the electrode in the brain and we stimulate, sometimes the current also affects other parts of the brain. No surprise. Usually, though, that's minimizable by adjusting which electrode we use, by adjusting the voltage, and by adjusting other parameters. Some of the things you could feel, though, that we would consider complications or risks include reversible paresthesias. That would be a buzzing or a tingling sensation in part of your body. Dysarthria, or difficulty speaking, and muscle contractions in parts of the body. Again, we are able to usually minimize or eliminate those by controlling the stimulation. So how do we do surgery? So before surgery, you would come, you would have met me, you would have met Dr. Bajaj, you would meet other parts of that large team that I introduced you to at the beginning of this talk. We might order more tests. And this is the most important part, maybe, of the whole talk. So before we do anything, we would make sure we agree with your diagnosis, and we'd make sure that we don't think there's anything else we could do before we talk about surgery. We would make sure that we think your medications are maxed out, that there's not a medication that no one's tried on you that might help. If all those things are met, then we would sit and we would talk about surgery. So say we decided we were going to operate, and you agreed. So the day of surgery, what would happen? Well, you'd come into the hospital, we put a special frame on your head, and we take another MRI. And this we call targeting. And then we make a map, a virtual map of your brain. So we're trying to put the electrode in an area the size of an almond. So we do this very precisely. So we create this map, and then in the operating room, we listen to the cells in your brain. You'll be listening too. You're awake. And the cells in the brain, each type of cell makes a different sound. A lot of it sounds like listening to the radio on a station that's not received. It sounds a little like static, but there's different types of static. And so we know what the right type of static is, what the right sound is, and that tells us that we are where we need to be. Then we're going to test the electrode. In other words, while you're sitting there in the operating room, we're going to put a little current through there. We're going to make sure, A, that it doesn't cause any of those other effects that would be too burdensome to you, that you would say, this is not going to work, which might mean we'd need to still look for another area in the brain. B, we're going to look and see if that helps us. So let me just show you this little picture of, this is in the operating room. So this is a patient with Parkinson's disease. You can imagine that they're having significant difficulty. They're holding a cup. They can't really write because of their tremor. So we're putting electrode we're putting electricity through their lead. You can see the immediate effects. Well, not everyone will have immediate effects like that, and it's certainly not something that if you don't have this result in the operating room means anything poor whatsoever. If we see that, well, that's just, that's the cherry on top of the sundae. But if not, the programming can take some time, and it can, depending on what your symptoms are and how your medications are being managed, it can take more or less time. Then we're going to fix the wire in place, and we're going to close up everything. So typically, you can go home the next day if you feel up to it after surgery. No one kicks you out of the hospital, but if you feel up to it, you can go home the next day, or you stay until you feel up to it. And then 1 to 2 weeks later, you're going to come back to surgery. And this time, under general anesthesia, is when we put the battery in. So we have to do that under general anesthesia. The first part is a long enough part of the day. We don't like to do that at the end of the day. So in the meantime, you're obviously getting no electricity through your battery, and you're going to go home, and you're typically going to be your same Parkinson's self with your same symptoms. Some people do a little better just from having the electrode put in there, but that's a topic for another discussion. So what is the equipment? So the equipment we talk about is the electrode. So this is the electrode that goes in your head, and we call it a quadrupolar electrode. There are 4 contacts. So there are 4 different spots we can stimulate from. And what that does is gives us a lot of options in terms of what are we going to do. The subthalamic nucleus is small, but it's not so tiny, and different parts of it actually are involved in different things. So it allows us a little bit of freedom to try to maximize your benefit. We put, actually we're using a different cap these days, but we put a cap, this is put on the skull, under the scalp. You typically can feel a little prominence there, a little bump there, and this holds the electrode in place. This is the battery with the connection, with the cables. So this battery goes in under your clavicle here, and it's like a pacemaker battery. And we have programmers. We have a programmer for the patient. So some people, depending on how Dr. Bajaj decides to program you and what your desires are, some people like to have some control. Typically, we only give you control of the juice. You know, you can go up or down on the juice. But this controller will allow you to do that. And then we have a controller that we use. So we do this it's a remote control that we put up to your skin. But to answer your questions, to change the settings, you don't need another operation. It's done by holding something up to your skin and by pushing buttons on this monitor. It's a little bit like your television remote.
How long does that device last?
The battery? So we say about 3 to 5 years. So depending on your settings, depending on how much juice you're using, about 3 to 5 years. When the battery is exhausted, you can come back in, and it's an outpatient procedure, like, again, changing a battery if you had a pacemaker in your heart, where we numb in the operating room. We do it because to do it cleanly and safely, we numb up that area, we open that area up, we change the battery, and then you go back home the same day. So after surgery, your first programming would be 2 to 4 weeks after surgery, typically. And you might need a couple of adjustments at the beginning. It's a bit of a trial and error. We have certain algorithms. In other words, we know how we're going to try to program you, but we don't always know how that's going to feel to you. And sometimes it might seem great in the office, but you go home and you're like, you know what? It's too much. Or you know what? It's helping this or it's helping that. Yes, sir. So the surgery on the head is done with a lot of local anesthetic. We will put the frame on. We'll put you in kind of a twilight state to put the frame on. That's usually the most uncomfortable part. In the operating room, I need you cooperative. And most people actually have no problems. It sounds very scary or like some horror movie or something you'd see on ER or whatever television show. But you're not screaming in pain. The brain has no pain sensors, actually. The skin does. So we numb the skin up. But when we're working in the brain, you don't actually feel anything. It can be a little uncomfortable. You're not on your medication. You're off at the time. So you haven't had your Cinemet, so you're a little slow. You might be frozen. We try to give you some right towards the end to try to help you through it. But we need you awake for 2 reasons. One, so anesthesia, the same anesthesia that puts you to sleep, puts those cells I was talking about to sleep. So if you're asleep, I can't hear what those cells are trying to tell us. So it makes surgery a little harder because of that. And the second thing is we're trying to take care of you here. We're trying to actually take care of your symptoms. Well, I need to hear from you what we're accomplishing. I need to hear if I give it a little electricity there. If you say, ooh, my tremor feels worse, or oh, I feel tingling down the side of my body, I need to hear that from you. And there's no test if you're asleep that I can do to get that information. But we make you very comfortable as much as can be possible, given the situation. But it is not painful.
What about flying? If you're flying with that?
There's no problem flying. You get again. I don't really know that much about heart pacemakers, despite talking about them a lot. But you get a card, like I think they give you if you have a heart pacemaker, that says I have an implanted metallic device, and I guess they just pat you down. But there's no problem flying.
What happened? I have problems flying because I go to the off period when I go to fly. I don't know if for some reason it's excitement or what.
You go. I'm sorry. You.
I have problems flying. I don't have a stimulation.
Right.
But I have problems flying, and so I have to be escorted on the plane, helped on the plane, because I go in an off period at that time.
Right. Well, the effect same in your off period if it's